Good afternoon. So this is not a very new topic to you all. I will just share my views from being an IEC member for the past 10 years. So you must have come across these terms, IRB, ERB, REB, they are all the same. So from the morning you have been listening to lectures on how to do, what to do, and most of you have submitted your protocol also. So you must be having a big breath. Okay, I have submitted, somebody will do the study for me. Now, there is somebody to monitor it. And that person or a committee who will monitor your study is the IEC. So I'll just run through what we do at IEC. We have meetings every 3 to 4 months. So I'll be telling what is this IEC, why does an institute have to have a committee like this? So we should know a small history about that. So the basic Hippocratic Oath says, do no harm. So the same applies to research also. Your interest is different, patient's interest is different, but your interest should never take precedence over the patient's interest. It should go hand in hand. It should be like a railway track. Okay, it should not cross. So your interest should never take precedence over the well-being of the participant, and never say subject. I came across many protocols where you had written subjects. You're not subjecting them to something. They are all participant. Without them, you cannot participate in the study. Okay, so they are all participants. So why at all a committee has to be formed? So when we see history, there were the era of Nazi experiments in the Second World War, when the prisoners were subjected to horrible experiments just to study the effect of high altitude, the effect of freezing. They were just dipped into ice cold water, or they were just hanged in high altitude just to see how many hours can a person sustain. So those were the time where the experiments were like that. Then we all know about this thalidomide tragedy. Why did that happen? Because drug was given for hyperemesis. But that was a wonderful drug. No doubt about that. Still, it is used for leprosy or multiple myeloma. But that drug trial was not conducted properly, and there was no proof that it can cross the placental barrier. So that led to almost 10,000 children being born with such deformities. Then the Tuskegee experiment. You can see that it ran from 1932 to 1972. What was this experiment? They wanted to study the natural course of syphilis. So what they did, some contracted syphilis, some did not have syphilis. The US, American, African prisoners, especially Guatemala, some were even injected with the syphilis. So they wanted, penicillin was available at that time, but they were withheld from the treatment. 1972 is not very far. Penicillin was very well available, but the doctors who conducted the study knew that penicillin is the treatment, but they were deprived of the treatment just to study the natural course of the disease. So just when I'm narrating itself, I can see the reactions in all of your faces. This should never happen, right? So that's what the world thought. Okay, we should, after the Second World War, we should put an end to such inhuman activities. That was the first Nuremberg Code in 1947. Then one by one, they also started refining. Okay, we should bring this declaration. As we do know, say when we do something, then we will know, okay, we will improvise. Then the famous declaration of Helsinki, because this you will be using in all your protocol. My protocol adhered to the Declaration of Helsinki. Then came the Belmont Report, which said that the participant should benefit. Then there was a common rule. You cannot differentiate between participants. Then finally, 1996, there was a concept of good clinical practice. So from this only, all the PPPs, that is preferred practice patterns, came into vogue clinically also. So when this is in the world, what is happening to India? And finally, UNESCO came for the Universal Code of Ethics in 2005. Now in India, so we started in 1980. The first ICMR came up with the first guidelines. Then there was an ethical guidelines, which was very brief on biomedical research on humans. Then the CDSCO came. When it was a big unified committee. When the Indian GCP came, the first we had good clinical practices universally. Then for Indian scenario, we had one guidelines. Then the age-old 1940 Drug and Cosmetic Act was revised in 2005. It took a long time for that. Then stem cell research came in 2013. And finally, we have the latest is 2017 National Guidelines for Biomedical and Health Research involving human participants. So it is a very neat and comprehensive booklet. If you have any doubt, it is freely available in the net. You can go and refer to that for any doubts if you have. So ours is also a registered ethics committee. So that committee told all the ethics committee in all the medical colleges, university has to be registered. So ours is one of that. At present, there are 1,260 ethics committees in India. So it is actually an independent board. It doesn't belong to Aravind Eye Hospital, either Pondicherry or Coimbatore or Tirunelveli. The members, the clinicians are only a part of the ethics committee. So ethics committee, why is it there? Because the members' responsibility is to approve. We have approved most of your projects. Yes, we will monitor whether it is going in the right pace, whether it is going in an ethical way. We will review it periodically. Why? Because we are dealing with humans. We have to safeguard their dignity, rights, safety, and well-being of all the research participants. And it also determines whether the research methods are scientifically sound, because whatever is not scientific, it is not ethical. See, as I told, right? Penicillin was not given, it is not scientific. So that itself, the first point, withholding a medicine is not scientific. So it is not ethical. So whatever is not scientific is not ethical. That's it. So that's why you would have submitted to the scientific committee first for the scientific content. And then it comes to ethical, for ethical issues. So when I just told that it doesn't belong to hospital and clinicians are only a part of the IEC. So whom do we have? We have a chairperson. We have a member secretary. We have a social scientist, that is persons who have done sociology or psychology, something. Social, they are non-medicos. We have a basic medical scientist, that is pharmacology, pathology or microbiology persons. Basic medical scientist, and clinician is only a part of it. Okay, clinicians are not the hardcore persons. We have a layman. By layman, we don't mean illiterate persons. They are not related to medical profession. Like it can be a bank employee, it can be a teacher. That's it. So they are not belonging to any of these category. That is why it is put as layman, but doesn't mean they are illiterate. So they are not a social scientist. They are not a legal expert. They are not belonging to medical fraternity of any kind. So that is a layman. But preferably 7 to 15 members are there in any IEC. It is made sure it is multidisciplinary and multi-sectoral because they represent the community from which you are going to draw the participation from. And at least 50% should be from outside the institution. Usually only 30% will be from the institute and 70% will be outside the institute. And minimum of 5 members, especially without these 5 persons, you cannot conduct a meeting. Though you may have 13 members, 12 members, but a lay person, a lawyer, a social scientist, a basic scientist should be there to conduct a meeting. Clinician, even if you have 3 clinicians in your committee and a lawyer is not present at that meeting, you are not legally approved to hold the meeting. So the minimum is legal expert, layman, 1 clinician, basic medical scientist, and a social scientist should be present for the meeting. Next, so what are we actually going to do in this? See what is ethics and all. So just all this. So when you go through this, you will know these are all very important. The risk and benefit for the patient as well as the community. Because when you do a study, after 2 or 3 years, basically it is you are going to give some information to the scientific community. Your juniors will follow that. So if you find that, okay, this intervention had some risk, they will take it in mind. they will have that in mind and take appropriate measures. That's why. So what is the type of risk or the any injury, informed consent process, conflict of interest, privacy, confidentiality, payment, compensation, what is a vulnerable population, approach research benefit sharing, and a research misconduct. They will all come under ethical issues. So risk and benefit. So just now Christy told that benefit is not, mostly it is not to the patient themselves, because it is a study. We do not know whether your intervention or whether your drug or device is actually going to benefit. We think that it will, in good will, we think it was going to benefit for the patients, but it's mostly for the community or society, because based on this, we will be doing the next research. It can be direct or indirect, but the risk can be anything. It is mostly to the participant themselves. It can be physical, psychological, social, economic, or legal. So just now, this was also, because this is recovered, because this is a very important point, and this is from the 2017 ICMR guidelines, less than minimal risk. So I have given the example also. So it is data which is in the public domain or anonymous data. It is less than minimal risk. Whereas minimal risk, your routine questioning itself is a minimal risk. You have to think. So none of your studies is less than minimal risk, because you will be asking basic data from them. And the routine test, they all come under minimal risk. Okay, like see, physical examination, chest X-ray, obtaining body fluid without invasive intervention, like even taking a sputum sample without intervention. So all that comes under minimal risk. But when you give a puncture, like a small sample of blood, it is minor increase over minimal risk. And more than minimal risk or high risk, it's invasive interventional study using a drug, which is generally we will not give those type of study for postgraduates. So research-related injury can be an adverse event or a serious adverse event. Adverse event does not necessarily have a causal relationship with the intervention. Like you may do a study with an astigmatism after cataract surgery, but the patient can develop endophthalmitis because of cataract. Is it because of your study? No. Your motto is to study astigmatism after a particular type of toric IOL. You are going to do an observational, but that is an adverse event for the patient, yes or no? For the participant, it is an adverse event. So you have to, in your explanation, PAS, you have to write, you may have side effects, which is not a part of the research, but it can be a part of the normal procedure, right? They can develop CME, they can develop PCR, they can develop endophthalmitis. They are all adverse event for the participant, but they are not adverse event because of your study. You have to keep in. So that must also be reflected. For example, if you're doing a study on fundus fluorescent angiography, the patient can develop anaphylaxis. So in that case, you may have to write that also. You may develop allergic reactions during the study, for which you will be treated in such and such a place. There may be a rare cause of death also. You may have to mention that in your PIS. So that is the serious adverse event, death or life-threatening injury, which requires hospitalization or prolongation of hospitalization, significant disability because of your study, any congenital anomaly like that thalidomide, any congenital anomaly that can arise in future when you are studying a pregnant lady. Requirement of intervention to prevent permanent impairment of damage. So all this you have to think back, and if it exists, you have to put it in your PIS. Then informed consent process, as she told, it includes PIS and informed consent form. It is the responsibility of the researcher to make it simple. Okay, because it protects the individual's autonomy to freely choose. If not the participant, the attender can read, and so many times the attenders have come and asked, Madam, last time this paper was given to my mom or dad. They brought it home. So it says research. What is this? So then we will clarify it in the next visit. So that time also they will decide whether to continue or not. So it has to be obtained from the participant only after they understand it. and it should be impartial witness. So it should provide relevant information. It should be, you should make sure it is comprehended by them. So you have to teach the study coordinators properly so that they give the proper information to the participants, and it should be voluntary. Then conflict of interest. Suppose one of the candidate asked me, Madam, I'll take a control group. We will take our sisters. Can that be there? Can we just recruit our staff and do? Why? Because if I am doing that study, if I feel that this drug is going to be good, I will include my known persons also in that study, right or wrong? So that becomes a conflict of interest. So when the study, it concerns anything, it can be personal, it can be academic, or it can be political conflict of interest. So this line is very important. When the primary interest, when it concerns a primary interest such as participants' welfare or the validity of the research, it's influenced by a secondary interest. Secondary interest means interest of the researcher. So interest of the researcher should not influence the study. So that is the conflict of interest. For example, I'll tell you, yesterday we had a IEC meeting. One project was presented by Annamalai and Naveen. But in the decision making, we did not involve them. Though they are members of the IEC, we asked them to wait outside while the other members discussed about the pros and cons of this project. Every project, when you present, like all of your project had come to IEC, we will have a discussion about that. Say, what is this study? What is this? Is it scientifically possible in this setup? Is it okay? Is it ethical? But when you are a part of the study, when you are doing the study, you will not involve in the judgment process. Whether it is approved or whether it is rejected, that decision will not involve you. So that is the conflict. So when you have any conflict of interest, or you may be working for a pharmaceutical company, you may be a partner in the pharmaceutical company, and you will be a research, a PA also, or a secondary investigator also in that study. In that case, it is your financial interest or even an academic interest, because you may have your doing PhD and you may have to publish that paper to complete your PhD. So you will have a conflict of interest. In that case, you will have to declare the conflict of interest. And if the conflict of interest is genuine, it's declared, then the ethics committee will consider it whether to make you continue as a investigator or not. That's it. So your responsibility is just to declare the COI. Then privacy, as the term suggests, it's very important. You have to maintain privacy and confidentiality of the participants. So it is the right of the individual. So in no way, in where you share data, for example, if your data is you are going to share it outside the institution, it has to be unidentified. You should not say Ramasamy, 55, male, nothing of that sort. All will be 1, 2, 3. That's it. Maximum male or female. That's it. No number, no age, no area. All identity should be de-identified. Because the data, and it has to be mentioned in the protocol if you are sharing the data beyond the hospital. And always when you get consent itself, get a consent for publication also, because our ultimate aim of doing a study is to publish it. That's it. Then payment for participation. This query you will get from your patients. Whether will I get any payment if I participate in the study? Usually, we will not give direct payment because it will be an inducement to participate in the study. That will actually, it's a bias. You can't, just because you're giving 1,000 rupees, the patient should not come into your study. You should make the patient understand that this is your disease. We are going to study about this disease and we are going to get some information. So it should be voluntary. But they are losing their wages because they are coming for 1 or 2 extra follow. They might actually not need to come at 10 days or 1 month. Usually the follow-up for that disease is 3 months. But for your study, if they are coming at 1 month or 2 months, that means they are losing their wages. So that you can give as a payment to just compensate for the travel or their daily wages, exactly. And the same way, your participants should not pay for their expenses because they are a part of your study. So the hospital has to take the responsibility of the charges. We have to waiver the charges as in any control group also. So because I want to study glaucoma about IOP in a 30 to 40-year-old glaucoma patients on this. So I want 30 to 40-year-old. Okay, I take 30-year-old who come for RR, routine checkup, glass checkup. For that patient also, I have to make HFA and OCT free, not only for the glaucoma group. Okay. Then compensation. So usually for PG and fellows, we do not have any interventional trial. So there is not going to be great harm. But all the research proposal, if it is an interventional trial, should have an inbuilt provision. And the researcher is responsible for reporting all the adverse event within 24 hours to the IEC. If it is an adverse event, it has to be reported within 2 weeks. But if it is a serious adverse event, which I mentioned earlier, like hospitalization, loss in disability or death, it has to be reported immediately. Then vulnerable patients. Can you say what is an example of vulnerable patients? Am I vulnerable? Who in our hospital is vulnerable? Come on, it's not an exam. Children, yes, all children, less than 13, less than 18 for that matter. Then pregnant women, wheelchair bound patients, elderly, one-eyed patient. Yes. So it's that is the definition is they are incapable of protecting their own interest. So that is defined as vulnerable. So children, those with cognitive impairment, for example, you may have to do a study on cognitive impairment, children with cognitive impairment. So that doesn't mean you cannot do a study on them at all. Just you have to declare that you are studying on a vulnerable population. For example, if I want to study on glaucoma in pregnant women, I have to include pregnant women only, right? So that doesn't mean that I cannot do a study on vulnerable population, but you have to take extra care. For example, if it is a children especially, you will have to give a separate PAS for the children. That is, you have to address to the parent. Your child is being taken for this study. Your child has this problem. So all the PAS has to be addressed to the father instead of the parent, instead of the child, so that the parent understands and gives consent. So, and the vulnerable group, the last point is very important. They should be included in research only when the research is directly answering the health needs or the requirements of the group. For example, if a study can be done without them, I can exclude pregnant women. I can exclude patients more than 70 years. I can exclude wheelchair bound patients. I can exclude patients with cognitive impairment, right? So most of the studies which do not need them necessarily, you have to exclude them. That is the only thing. Then post-research access and benefit sharing. So when you're doing itself, you come to know that one arm is very good. What do? So 50 patients in this arm and 50 patients in the arm B. When 50 patients, around 30, 35, when you come to know that this arm is doing very good, whereas this arm is doing very bad. What will you do? You'll stop the other arm and that should not be done. You can incorporate this information in your routine standard of care. Okay, so that is called benefit sharing. And post research access, like a new drug, new technique has come when the study is going on. So after the study period is completed, you can tell the patient that this technique has come now. So when you were being treated, this technique is not there. Now we have this. We have come to know because of this research. So we will like to give this treatment to you. You have to share that information also. Then research misconduct, what you should not do in research. This is also from the ICMR page. So main thing is fabrication, never make up data. because it will, statistician will definitely find it out if you make up data. Then falsification, that is manipulating in the due course of research. You have told I will follow this protocol, but you are following something else. So you're manipulating the research material, equipment, process, the protocol. The process means the process of the study, or omitting or suppressing the data without the scientific or statistical justification. That is falsification. And plagiarism, you're just copying somebody else's data to yours. So that's all research misconduct. So in a nutshell, what are the functions of IEC? It is to ensure basically the right, safety, well-being, and dignity of all the participants, and to ensure a ethical conduct of the research by you all, responsible for the declaration of conflict of interest to the chairperson, because if we are not looking at it properly, tomorrow if there is a conflict of interest, somebody sues saying that this investigator was a part of this. So the ethical committee is responsible for that. And it is to assist in the development and education of the research community. It ensures that privacy of the individual and confidentiality of data, to review the progress reports, final reports, adverse events, recommend the appropriate compensation, and carry out the monitoring visits at the study site as and when needed. And finally, the circumstances that require the matter to be brought to attention of IEC is any amendment. Like you are thinking, for example, you are doing only with OCT, but then you think OCT A might help in the middle of your study. So you can amend your protocol without much change in the design. Like you cannot make a observational study into a randomized control study. That is not possible. Without a major change in the study, you can make small amendments. Like you think if 50 participants would be sufficient, but then you think, no, I'm getting more patients. So you can start recruiting more patients in your study. So that is all amendments. That is to be informed to the IEC before starting, like you're amending. You have to submit the amendment to the IEC and then make the changes in your protocol. Then any SAE, any new information that may influence the conduct of the study. Then after you get your approval from the research committee and IEC, you will have to register with CTRI, because it is a mandate now for clinical trials and for any publication. Whether it's the PG thesis or any research for publishing, they will ask your CTRI registration number. So never start your study before submitting to the CTRI, and they will give a confirmatory mail with the primary investigator, and then only you have to start your study. That's it. Thank you.